From STS, we have Leanne, Addie, Emily, and Melinda. And Darlene, I see your hand up. Not sure if you meant to put it up, but we'll get to you in just a few minutes. Hopefully everybody's on. And happy Easter to all those who celebrated. Happy Passover to all those who celebrated. And thanks for joining. Today is April 13th. This is the STS Adult Cardiac Surgery Database webinar. And we're going to have some STS important dates. We're starting a new quality improvement project for the national database. And we're going to pilot it with adult cardiac, and I'll get more into that. I'm super excited about it. And then we'll hand it over to Melinda for education on risk variables, tobacco use, home oxygen, sleep apnea, and pneumonia. Okay, and then I'm going to shut down the chat box. So if you could just be sure to put your questions into the Q&A, and then we'll get to them as soon as, as soon as we can following the presentation. And here we go. So first up is important dates for adult cardiac. Today is April 13th. Our webinar is a little different. Sorry, I had to move it from last Wednesday. I was standby for jury duty. Didn't get called. Would have been okay if I did, but that's all right. So I moved it to this. This was the only day that was open this week. And it was the only time that was open for a webinar. April 17th, we're expecting the Harvest 1 reports to be released this weekend. We'll send official notification on Tuesday, April 18th, and the IQVIA notification tab will be updated on Tuesday, April 18th, but don't be surprised if you see your reports populate Sunday and Monday. They'll be coming through this weekend. And that's Harvest 1 through Q4 data. That will be your star rating. April 19th we're kind of sunsetting the user group calls, and we're going to go over to a new series called the Quality Improvement Series. This will be for the STS National Database for Adult Cardiac. We'll do our other databases once we are successful or see success with this initial program. So we're going to do a kickoff on April 19th, and I'll talk more about that in the coming slides. That call will be at 2 p.m. And then we're going to have a second call, planning 2 calls a month for this project. Starting this month, we'll have 2 calls in April, 2 calls in May, and 2 calls in June, specific to this, in addition to our monthly webinar, which is the first webinar of the month. So please notice the times. On the 19th, it's 2 p.m. On the 27th, it is 1 p.m. Central. Those are Central times. That was the only time we could have it on these dates. So just pay attention to the times on the invites and keep watch for notifications. April 30th, if you've consented to TVT public reporting, nothing to do. If you haven't consented but are interested in consenting, be sure to get your consent forms in by April 30th. Anything after April 30th, any consent that's sent in after April 30th will get deferred to the 2024 posting. So if you want to be included in the 2023 public reporting update for TVT, that's your TAVR composite, be sure to get those consents in by April 30th to the ACC. May 3rd, we have our monthly webinar at 2 p.m. and we'll be going over the Harvest 1 report, which is due out this weekend, and then preparing for Harvest Close, which happens on May 19th. May 7th through 8th, I'll be reaching out to sites who are at risk for exclusion from Harvest 2, similar to what we did for Harvest 1. If you receive a notification from me, I'll try to make it as personalized as possible. Last time I had to reach out to hundreds of sites, so it was very difficult to make those emails, to personalize those emails unless I was reached out to. And when I was reached out to, I sent additional information. But just note that if you receive something, it'll come sometime in the week of May 7th, 8th. May 17th, we'll have our Quality Improvement Series. This will be the second webinar focused on that. More to come. And then May 19th is Harvest 2 Close with OR dates through March 31st, 2023. May 25th is another Quality Improvement Series. All right, so the Harvest dates, nothing has changed. We're at Harvest 2, closes on May 19th. The opt-out date is May 23rd. It'll include procedures from through March 31st, 2023. and it'll be populated. It'll be back to you sometime in the early summer. We had quick turnaround with Harvest One reports. Last year, they came out in May. So a quick turnaround with bringing analytics in-house to the STS Research and Analytics Center. I expect to see similar fast turnarounds as they become more proficient at it in with the Harvest 2 report. So looking forward to that quick turnaround for sites. And now STS updates. April training manuals posted. Harvest 1 Q4 data is expected to be released this weekend. An official notification will be sent out on Tuesday, but don't be surprised if you see it on the IQVIA portal Sunday, Monday, or Tuesday. And then the STS National Database Quality Improvement Series. This is the one we'll be focusing on to begin with. We're going to be focusing on reducing vent times nationally. Our kickoff call is April 19th at 2 p.m. And that leads me to this next slide. So one of the things I've been asked to do is to work with sites nationally on these webinars to use the data to show value of the database and in ways other than just reporting and star ratings. Even though those show how well your sites are performing, there's things we can do nationally that makes the data more actionable. So the plan is we're going to show value of the database outside of just reporting. It'll make the data actionable. We're going to show how important you are in data abstraction because we're going to improve patient outcomes on a national level. We're going to start with isolated CABG procedures and vent times. We'll be looking at total vent time from OR exit to initial extubation, including extubation times, and decreasing that on a national level, as well as, which will likely be a byproduct of decreasing prolonged ventilation rates. It's going to be part of a national team effort. I don't know that other databases have done this. I'm super excited about it. I'm proud to be leading this. So I look forward to working with all of you. And if you are not the person that is leading these quality improvement projects at your hospital, we're going to talk about that in a second. But the plan is that over the next couple reporting cycles, to see decreases in vent times. And by doing that, we'll be improving patient outcomes. And did I mention patient outcomes? So that's kind of the point of the database and of the STS as a whole, is to provide the best care to our patients. And also because it's going to be awesome to work towards something together on a national level. I mean, think of all the power we have on this call and all the people we have who are doers that will be able to make something big of this. So I'm really looking forward to it. More to come on this, but I'm going to go over this sort of initial plan that I put together. I don't know, can you see the top of that? The kickoff call, like I said, will be April 19th. Dr. Glenn Whitman will be joining us. I think I have, yeah, so I'll go over that in a second. But the idea, and I just put it in the DMAC format for those of you who are aware of process improvements and Lean Six Sigma or any type of process improvement methodology. I just use DMAC, which is familiar to me, which is define, measure, analyze, improve, and control. To define it, we're nationally decreased ventilation times for post-CABG population over the next 12 to 24 months. We're going to measure this quarterly using the ACSD harvest analysis reports and longitudinal dashboards. Now, this is just a snippet. We're going to get in more detail on this coming up on the 19th when we kick it off. The measure portion I have is Harvest 4 analysis shows a mean national vent time benchmark of 15.07 hours. We know that early ventilation, and Dr. Whitman will get into this, we know that early extubation of 6 hours or less really has an impact on patient outcomes. Right now, our national benchmark is 15.07 hours, so it would be great to see that decrease on a national level. Prolonged vent time risk adjusted rate is 6.5% for the 3 years analysis of Harvest 4, and a risk adjusted rate So if you look at it on a quarterly basis, I looked at Q3 of 2022. Our risk adjusted rate nationally is 5.28. So over the 3 years, it's a little bit higher than what we performed last quarter. To analyze it, I said we'll use the STS harvest reports and longitudinal dashboard. Sites will implement processes at their sites to decrease local vent times and decrease prolonged ventilation. And this is where you'll get buy-in from stakeholders and those who are really involved through education and encouragement to get processes in place to foster early extubations and things like that where appropriate for patient care. STS is going to provide education and support for these processes. To improve, we'll engage site leaders who have already accomplished decreased both event times and prolonged ventilation percentages to provide education and webinars and be available as resources. And at the end of this call, I could do it right now. I would love for anybody, and I have some lists of people, especially the Virginia Collaborative. I would love for people who have already done these projects internally to reach out to me, because I want to get you on a webinar to share your process, what you did, and how you used the STS database internally at your site to improve early extubation, decreasing vent times and prolonged ventilation. So if you have already done these projects, please reach out to me and share your name and contact information with me so I can work with you to get you scheduled on an upcoming webinar. Otherwise, I'll be leading the webinars myself, but it's pretty boring when I'm the only one talking. So really great if you all are interested in doing that. The next step, of course, is control. So we'll track this monthly to see improvements nationally, and then we'll talk about ways if we're not seeing improvements in a couple reporting cycles. We'll talk about things that we're doing and things that we could do better through all of you at site. So I'm really excited about this, and I think it's something cool and something different that we can do together, and it'll be neat to do it as a team. On April 19th, Dr. Glenn Whitman from Johns Hopkins is going to present on the clinical aspects of ventilation and prolonged ventilation. I'll talk about engaging stakeholders. Number one, our stakeholders are our patients, so improving outcomes and things we can do for patient education and early ambulation, things like that to help improve the outcomes. The decrease of bad outcome, the risk of bad outcomes, we decrease cost and resources. So your C-suite folks will love that. And then improve star ratings, which your surgeons, you're kind of, we hand all this data over to the surgeons and say, here you go. But we know our surgeons are really busy and they can't, it's not actionable unless we help them with it. So improving star ratings and then showing your value and how you can help make this data actionable at your site for all of these causes. And then my question to you prior to this April 19th kickoff call is, are you the person who's able to institute quality improvement projects at your hospital? A lot of times, and we saw on the data manager survey, about 60% or so of those who responded to the question about have you used the STS for internal QI projects, about 60% had. That means there's about 40% who have not. And oftentimes, we have a group of data managers who are highly skilled at what they're doing with a lot of knowledge, abstracting data, but not able to use the data or not in a position in their hospital to use the data. But oftentimes with that setup, there's other people in your hospital who are the quality team, right? Your quality improvement specialists. So how can we engage those folks so you can work together? And if you're not the person who's able to institute these quality improvement projects, please reach out to your quality team and ask them to join the webinar on April 19th and going forward so we can all work together. We don't want to leave your site behind in this national endeavor. So that's my spiel. I hope that you all will join on April 19th. And if we're able to do this, I think we should all be very proud of ourselves, even just for taking on the initiative. So All right, I'm done talking about that. STS updates and support plan. If you have any questions about participant reports, IQVIA dashboard login, you'll reach out to the STSDB_help desk at sts.org. For updates to contacts, contracts, and other general questions, stsdb@sts.org. And Linda, now it's your turn, but first I want to see the questions and comments.
Yeah, you want to answer those questions?
Yeah, let me go
first,
through these real quick. So Danette's asking, when does public reported get updated? Thanks. My request, so I know for STS, the adult cardiac public reporting will get updated late summer, early fall. For TVT, it'll be updated around the same time. When does the cardiac surgery? So I just answered that. If anyone has a smart set created in Epic for perfusion or surgeon documentation, let me make sure I have these. Okay, yeah. So hopefully people can see your comment, Laura. If anyone has a smart set created in Epic for perfusion or surgeon documentation, especially for perfusion, will you please send me a copy? And Laura put her email there from Geisinger. Well, we get emails for these meetings. Yeah, it'll be just like we do for the regular webinars. What is TVT public reporting? If you participate in the TVT registry, which is a registry for TAVRs, TMVRs, tricuspid, transcatheter tricuspids. If you participate in the TVT registry, we have public reporting available for our TAVR composite. We also report out volumes and time within the registry. If you have more questions on that, Leslie, please send me an email. I'm out the rest of the week, but I'll respond on Monday. TAVR composite. Yep, TAVR. Oh, I answered your question. Look at that. Was there an opportunity in 2022 to consent for TVT public reporting? Yeah, TVT public reporting is run a little bit differently than the STS databases because it's a joint database between STS and ACC. Their consenting is open year round, 365 days a year for TVT, similar to the other NCDR registries, but we have a cutoff of April 30th each year to be included in the update to follow. So the consenting period for 2023 ended on April 30th of 2022. Let me restate that. The consenting period for 2022 ended April 30th of 2022. That data refresh occurred in July, August. I can't remember. I think it was early August 2022. And then those who consented after April 30th of 2022 are included in the 2023 consenting pool. So those who consent from May 1st, 2022 through April 30th, 2023 are included in the 2023 refresh of public reporting. Does STS need a separate consent for TVT, or is STS ACC site consent included in the ACC's consent? So Carly, you'll want to reach out to ACC regarding the consent or the data release consent form for TVT. You can go to their NCDR portal and find the DRCF, the data release consent form there. It's separate than STS. It's a whole separate thing. To be included, must have 60 cases each year for 3 consecutive years. It's 60 cases total. It doesn't have to be each year. It's 60 cases total over the 3 years for the TAVR composite. Is there anyone who utilizes Epic that would be willing to connect with me regarding documentation utilized for vent time? Erica, if you want to, oh, there you go. And I think Mary connected with you, so that's great. Thank you, Mary and Erica. Will there be a meeting notice sent out for the April 19th meeting? Yes, we'll send that out. There you go, Sue. There's the support slide. Any discussion about when we can stop tracking COVID data, getting harder to find out now that cases? Yeah, I was just thinking about that, Amy. Next time I talk with I guess maybe we could add that to the core group, Melinda. Because we've been tracking it now for 3 years. So I'm just wondering, maybe we can, something we can discuss with our surgeon leaders.
Mm-hmm.
What dates will be included in the next ACSD public reporting? It's going to use Harvest 1 2023 report, so data through December 31st, 2022 for ACSD public reporting refresh. Would you please send email invitations for the 19th that I can forward to my department? It will be coming. The other thing, Robbie, the other thing I suggest for your question about sending email invitations to be forwarded to your department is to perhaps send them when this video is posted, send them the copy of this video or the slides, and then a link to the webinar page on the STS. If you have any questions, email me and I'll send those over to you when they're. Thanks, Lisa, for your email. When looking at the ACSD public reporting site, it says composite data through December 21st. We have had star ratings released since then, but the public reporting page hasn't been updated. So Erica says, when looking at the ACSD public reporting site, it says composite data is from January 2019 through December 2021. Haven't we had star ratings released since then? Yes, we have star ratings released since then, but we don't update public reporting with each star rating release. We typically update it once a year using the end of year data. So the next refresh for public reporting will be with OR dates through December 2022, which is Harvest 1 2023, due to be released this week coming up. Laura, I think we all need the smart phrase for Epic. Abstracting the perfusion information for us right now is very challenging. So thanks. And I don't know, Leanne put information in the chat box regarding the original question from Laura for the smart phrases. But if anybody would like to share their email again. Thank you, Karen. So okay, so let me go here. Then there's the timeline. I posted that. When will sites be notified this year regarding audits? Emily, did you want to take that one if you're able?
Yeah, I would say probably May is the timeline we're looking at right now.
Okay, thank you. And there's another email from Heather about the perfusion smart phrase. Okay. And then, so to clarify from Erica's last question, the public can't see any scores or star ratings since December 2021. Correct. We updated once a year using the end of year data. Oh, thank you. Thank you, Sharina. If you could please just email me, Leanne, if you don't mind putting my email in the chat box. If you could just email me, I'll connect with you early next week. Thank you so much. Any updates you can share regarding the aorta data and star ratings coming with those cases? The aortic risk model is still being finalized. I think they're preparing the manuscript. Once the manuscript is published, you'll be able to download that and read it. It will not start off as star ratings. That may come in the future, but to begin with, we'll just run it as a risk model. Okay. I can, Susan, I can share the presentation that I presented with the use of our perfusion sheet we created at Stanford. My email is there. What's the case count time period for the AVR composite rating? So all of that, Sandra, is in the national report overview posted on the IQVIA platform under the resource library. I'm going to stop with questions there. Thank you so much, everybody, for sharing your emails in the Q&A. I think that's super helpful to all your colleagues. Okay, ready, Melinda?
I'm ready. I'm going to have to go fast.
You got
All right.
time. You got time.
So we're gonna continue with our risk factor education, and today we're going to talk about tobacco use, home oxygen, sleep apnea, and pneumonia. And we're going to do a Q&A like we've been doing in the past. Next slide. So just a couple things to remind you: tobacco use, home oxygen, sleep apnea, and pneumonia are in the risk model. And in 2022, home oxygen, sleep apnea, and pneumonia were audit fields. Okay. All right, so question number 1. It's documented in the H&P that the patient uses snuff. Is this considered yes to tobacco use, which is sequence 400? A is yes, B is no. Can't see the poll. Carol, are you running the poll? Hello?
I should
I
have got
can-
off mute, huh?
I can see it.
Oh,
I can
Yeah, I
see it
am.
now. Now I can see
Yeah.
it.
Okay, I made you co-host again in the Leanne. I decided to take over the hosting role.
Well, a 75-25 split. Interesting. Okay, I think we can end it. It's pretty
Okay.
representative of what's going on. And the answer is next slide. Yes. Okay, so snuff, for those of you who probably aren't from the South, because snuff was really big in the South when I was a kid, is a smokeless canned tobacco. So it would be included as a tobacco product. All right.
Next slide.
Next slide. So, patient is a former smoker but vapes marijuana daily. Is this coded in sequence 400 as tobacco use? Yes or no? Now, this is interesting.
This is interesting.
It is.
This is why you're educating on it, Melinda. Answers are still coming in slowly, I think. You good, Melinda?
Yep, good. We got about 80-20. Okay, so and the answer to this question is yes. Now, why is the answer yes? Because in the training manual, any type of vaping should be captured. So we want to capture any vaping despite what the patient is vaping. I know that's a little kind of different, but it is in the training manual, and it was decided that that's how we wanted to capture this. The other thing I want to point out is that marijuana is not captured as an illicit drug. So I just want to throw that in there because it's legal in so many states these days. So if your patient is vaping marijuana daily, we're going to capture this in sequence 400. All right, next question. All right, patient quit smoking 26 days before admission. Surgery was done 5 days later. How do I code tobacco use? Current everyday or former smoker?
This is a tricky one, Melinda.
I know. And as I suspected, a split 50-50 up, 60-40 split here.
And as we're waiting for the answers to come in on this one, somebody asked, is smoking pot documented? If they are smoking pot, is that documented as tobacco use?
I don't think so.
Like, what if they don't vape Mary Jane, but smoke a doobie, as Shauna puts
Yeah.
it kindly?
I know. I think we have to talk about that. We pretty much made the decision on vaping because people are vaping so many different things these days. So.
Okay.
All right, in the poll. Let's see what the answer here is. Okay, so this patient quit smoking 26 days before admission, had his surgery done 5 days later. So we're going to code this as a current everyday smoker because in the training manual, when you read the definition, the current smoker is within 30 days prior to admission. Okay, so not prior to surgery, prior to admission. So that's the key here for this learning point here for this particular question.
Okay. Next.
All right. Surgeon consult note documents current someday smoker. The cardiologist note documents current everyday smoker. How do you code smoking status? Is it a current smoker, a current someday smoker, or is it unknown?
Another tricky one, Melinda.
Well, I try to, as I'm doing, making these slides, I'm trying to go through the training manual and look at things that, can easily get overlooked, or updates that may have been overlooked.
Yeah, no, that's great.
All right. So about 65% of the people answered A, which is the correct answer. So current everyday smoker. This was a very recent update in April of this past year. This was just came out in April. When there's conflicting documentation of the amount of tobacco use within 30 days prior to admission, we want to code the highest amount of tobacco use documented. So we would go with the current everyday versus the someday smoker.
Very good.
All right, question number 5. We're moving on to oxygen use. So we're switching gears. The patient is on 2 liters of oxygen nightly with CPAP. Should sequence 450 be coded as yes PRN or yes oxygen dependent? A is yes PRN, yes is oxygen dependent. (80-20).
What's sequence 450? Oxygen use?
Oxygen use, yeah. All right, so about 70-30.
I didn't know you could smoke cloves. I see some. All right, I'm interested in what's going on in the question back, so I can't wait to get over there later. Okay, ready?
Okay, ready. So the answer is A, yes, PRN. And the reason it's PRN is because this patient is only using oxygen at night. Granted, they use it every night, but they're not dependent on using oxygen all the time. Oxygen dependent, the choice for oxygen dependent would indicate that this patient wears oxygen all the time. So this patient's just a PRN oxygen use.
Okay, next.
Next. Okay, we're still talking about oxygen. Patient has an order for home oxygen, but has not used oxygen for 2 months. How is home oxygen coded? Yes, PRN, no, or unknown.
If I was abstracting, you'd be getting lots of FAQs from me, Melinda. Just kidding.
I get lots of FAQs all the time. So, I like doing these because I think the data, I think you guys enjoy doing this polling. I certainly enjoy seeing it. So
yeah, I like it too, and it's great for it's a great way for me to learn. So
okay, well, this is kind of an interesting split.
yep. All right, I'm gonna stop it.
All right, let's see what the answer is.
For all those people looking it up in the
training
manual.
So the answer is no. Okay, so this patient has the order for oxygen, but he hasn't used it in 2 months. So in the training manual, there's a specific instruction that if your patient has not been using oxygen for more than a month, to code no. So like I said, I'm just pointing out things that can often get missed in the training manual. That's kind of what this is all about. So
Yeah, these are like the little sentences that are hidden in between other sentences.
Yep.
That's good. Okay, next.
Okay, now we're talking about sleep apnea. So we're moving on to sleep apnea. The patient's family reports that the patient has sleep apnea. The patient has not had any formal sleep apnea testing. How is sleep apnea coded? Yes or no?
Ooh.
Oh, yay.
Yeah, this is good.
This is a good one. This one might have been too easy.
No, it wasn't. It was a good one.
It
gives us confidence, Melinda, that we might know a little something.
Oh, yeah, Carol, you got the answer right to this one, Carol.
Yeah. And when I say we, I mean me. I'm gonna end the poll.
All right, so 92% of the people answered this correctly. The answer is no. Okay, so the key here is that we're not going to capture suspected sleep apnea or apnea that family members report. Sleep apnea also can't be diagnosed with a screening tool. I know some hospitals do these little screening tools and they say, oh, this patient's at risk for sleep apnea. It's got to be, you got to have a formal diagnosis either by a provider or a sleep study saying that this patient has sleep apnea in order to code it. Okay. Next question. Patient has sleep apnea diagnosed with a sleep study. He lost 50 pounds before surgery, and a recent note lists that his OSA, which is sleep apnea, has resolved after weight loss. How is sleep apnea coded? Yes or no?
My goodness.
No. Real nice split here.
Yeah, this is my mind right now. 50-50 split.
Okay, I think we're going to pretty much be at 50-50 here. And the answer is, okay, so we're going to code yes to sleep apnea. If the sleep apnea is diagnosed using a formal diagnostic tool such as a sleep study, but it's not treated. So this patient has sleep apnea. It's not really treated. You don't have to have CPAP or BiPAP therapy. It's no longer a requirement to code it. So this patient technically still has sleep apnea. There's been nothing to surgically correct it. So he would still be coded as having sleep apnea.
If there was something done to correct it, like adenoids come out or something like that, do you still code it?
Well, we have a question about that. I think it might be
Oh.
the next question.
All right, I'll shut up.
If you're bursting my bubble.
I know, sir. But you should say, well, that's a great question, Kara.
That's a great question. Here we go. Yeah, I thought it was the next question. Okay, the patient has a history of sleep apnea that has been surgically corrected. How do you code sleep apnea? Yes or no?
Good thing you didn't answer my question.
I know, but I think I gave him a hint in my last answer. So I was like, Carol, that's my next question.
I know I didn't read the questions. I just pasted them into the slides. I like to be surprised,
80-20.
Yeah, I'm going to end it.
Going to end it. Okay, so the correct answer is no, because this patient has had his apnea surgically corrected, which means he no longer has sleep apnea. So we're not going to code him as having sleep apnea.
Ooh, I'm going to put my data manager hat on for a second. What? Ready, Melinda?
I don't know. Let's see.
Okay. What if the patient had weight loss surgery?
I think that it's different mechanism because there's two types of sleep apnea. And I think that's why, because there are a lot of skinny people that have sleep apnea because they've got problems in their, neck area and pharynx and all that causes the apnea. And then there's obese patients that have sleep apnea. So I think that the reason we kind of drew the line with the surgically corrected is because you don't always know what kind of sleep apnea the patient has. And I think this was just a cleaner cut as far as coding.
Okay, thank you. That makes sense.
All right, now we're going to talk about pneumonia. Put your pneumonia hats on. So the patient has a history of COVID pneumonia in 2019. The surgery was 12/14/22. How do you code pneumonia? Recent, remote, or no?
I'm with the majority on this one, so hopefully I got it right.
Me too.
Otherwise, we're all going to need a whole lot of education.
Well, I get this. I have when the COVID was really rampant, I got this question all the time. So I just wanted to highlight it.
That's good.
Okay, so 90% of the people say it's remote, and it is remote because just they've had COVID, but they had COVID pneumonia. So they did have a pneumonia. Okay. So you want to capture the fact that they had the pneumonia. The question I would get all the time is, well, just because it's COVID pneumonia, do you want me to capture this as COVID and pneumonia? Well, yeah, you want to capture it both because they actually had the pneumonia component of the COVID process. So, and it would be remote because it's more than 30 days prior to the procedure.
Good. All right.
All right, I think we just have a couple more. Question number 11. Patient has chronic eosinophilic pneumonia. How do you code pneumonia? Recent, remote, or no?
This is like the nursing boards. This is like the NCLEX.
Well, again, some of these are obscure, I think, in the training manual and can easily be missed. So it's good to point them out every once in a while.
It is. I agree. It's good.
And that's just, it's better than I thought it would be. Because like I said, this is one of those little comments just tucked away in the pneumonia section. So we have about a 50, 30, maybe more like a 60-40 cut here, with 60% of people saying this is pneumonia and 40% saying that this is not pneumonia. So what is the answer?
Answer is
No. Okay, so this was an update in March of last year, actually. Chronic eosinophilic pneumonia is not captured in the pneumonia field because it's not an infectious process. It's really just an accumulation of eosinophils in your lungs. So you would not want to capture it as pneumonia because it's not an infectious process. That's the key here. We're looking for a true pneumonia. All right, next. Last one, I think. Medical record documents possible pneumonia and antibiotics are started 5 days before surgery. How is pneumonia coded? Recent, remote, no, or unknown? Possible pneumonia.
I don't know why. I don't know what's going on. Hold on. Oh, there we go. Okay. Sorry about that.
I'm liking the direction this one's going in. All right, so we've got most of the people saying either no or unknown. And you know, those no's and unknowns do confuse people. Sometimes I wish we didn't have those two choices or the unknown choice, but I think the best answer in this situation, the way I would code it, would be unknown because it's possible. We really don't know if this patient has pneumonia or not. Of course, as you all know, unknown codes out, harvest out as a no. So it would. That's why I don't like the unknown answer for the most part, because some people want to answer this as no, and some people want to answer this as unknown. In my mind, unknown is probably the better answer because you don't know for sure, and you do have documentation that it might be possible.
I would code it as unknown.
Yeah,
You don't know.
but yeah, you don't know. So,
Okay.
all right, is that my last one?
No,
Oh
ma'am.
no, one more. Okay. Patient has a history of pneumonitis in 2010. How is pneumonia coded? Remote or no? So this is pneumonitis. So is this remote pneumonia or is this no pneumonia? Oh, good. About 90% of the people are on the no answer.
Yeah, and they were clicking the buttons fast, so they weren't looking it up.
Which is
But
the
it's
right.
okay if you look it up. That's how we learn.
That's how we learn. This is part of learning too.
Yeah.
So don't ever worry about, well, how you're answering. And the answer to the question is No, pneumonitis is an inflammation of the lung tissue, so it's not considered pneumonia. So a history of pneumonitis is not the same as having pneumonia. So you would code no to pneumonia. I think that's all I got.
Let's see. Yep, that's it. Now we're going to questions.
Right. And all those questions about the marijuana smoking and all, we're going to skip over those because that's something we're going to have to talk to the surgeons about. Because,
We don't know. We have to ask the surgeons on it.
yeah, we would because we talked
I
about the
don't think-
vaping with you.
Yeah, I don't
And
think, well, we don't, how do we code it for illicit drug use?
we don't code it for illicit drug use.
Yeah, and I don't think we code it as, unless it's mixed with tobacco, right?
Yeah, we don't code it for as smoking. So my gut is we're not going to code it as smoking if they're smoking marijuana, but if they're vaping, we do want to capture the vape use, which I know that's a little
Yeah,
at
don't worry about
times.
what they're vaping. If they're vaping, just code it.
Yeah, I mean that's the key. If they're vaping, we want to capture the vaping use. If they're smoking, we want to make sure it's tobacco. Okay. So we're going to leave it that way right now, and then we'll discuss that with the surgeons. So I'm not going to spend a lot of time answering those questions because I really don't know the answer right now. I think we need
We
to
should add, there's a question in here about cloves. Smoking cloves. I never heard of that.
Well, I've heard of it, but I think again, let's just make it clean. You either
Okay.
smoke tobacco or you vape, and we're gonna go like that, and just for now, unless we can get further clarification.
All right, here's one regarding the FAQ that was from April on fibrinogen.
Mhm.
It says, Melinda, for the April STS FAQ about counting fibrinogen that is given from donor blood in a blood bag, how is that documented in the chart? What should we be looking for documentation?
I think I put a picture in the training manual. I think Chris was kind enough to send me over a picture of the bag because I've never heard of such a thing.
Let's see.
And that sequence number is it 2545 or something like that? I think that gets us close. Could be wrong though. I hope you can get into the site. I couldn't
I
get
don't
in.
know if I can or not. It was down, right?
Yeah, you're going to be able to get in. Yay. Okay. So
2545 or near there?
near there, I think. Or we could highlight, do
Look
the
at that.
bookmark.
You're
There it
good,
is.
Melinda.
Yeah. Okay. So there's a picture of it comes in a bag, and this is much like what the bag looks like. It'll looks a lot like a regular like FFP bag, and it'll say fall full fibrinogen complex. And the surgeon, Chris sent me this question, and when we discussed this with the surgeons, felt like we really did want to capture this because it is actually a better product than cryo. And so we felt like the only place we could capture it right now is in cryo units. And hopefully with the upgrade, we'll have a special section for that.
And is this documented in the charting documentation? Is this usually in the blood product section?
Yeah, it would be in the blood product section.
Okay.
So I hope that helps, Marcy.
I think so. Okay. What if, so this is regarding the everyday smoker question. The patient who stopped 25 days or 26 days before was in the hospital for 5 days. It says, what if the patient has a prolonged pre-op admission of greater than 30 days prior to surgery, but smoked up to admission? Still capture as everyday smoker?
Yeah, I think because of the definition, it's clear that it's smoking within
Admit,
30 days prior to admission. Okay, so unless we change the definition, and that can only really be done with upgrades, then we'd want to continue to use the 30 days prior to admission.
Does all CPAP always use oxygen?
No, some CPAP machines, I think, don't use oxygen and others do. On the sleep apnea question, I don't know which question. We had 4 questions, Mary. What she's talking about.
Let me see if I can find it. Hold on.
Sleep apnea.
We don't have an unknown option.
Do we have an unknown option for sleep apnea? I don't
No.
know. I have to look. My brain
We'll look
doesn't
it up
remember
when you're-
everything. We
Yeah,
do
we do.
have an unknown. No, for sleep apnea 460. I don't think we have. I have to look at the data collection form. Mary probably
Oh, we
knows.
do have an unknown option.
So which question? I don't know which question Mary was talking about.
Oops. I'm clicking too much. Sorry, everybody.
Okay, so let's look at that. Oh, it may be the one, Mary, you talking about the one where the patient's family reports that the patient has sleep apnea? That's probably, yeah, I think that, I think I wouldn't capture unknown in this particular question because this patient has had no formal sleep apnea testing. So you have to have that, you've got to have some formal testing, a diagnostic, diagnosis of sleep apnea. So to me, it's not unknown. It's pretty clear that since you've not had any formal workup for the sleep apnea, you don't have it, even though your family says you snore really loud.
Makes sense. Okay.
Uh,
Next question. Just to confirm, if they are not using their prescribed oxygen, then we code no. However,
if they haven't used it for a month, greater than a month, we code no.
okay. And then I think there's a difference here between, and we're trying to make a comparison of 2 different questions.
Right.
And the difference is that the oxygen, if they really needed it, they would be using it, right? If you can't breathe, you're going to use oxygen, but
Right. And the diabetes, the difference between the oxygen and the diabetes that Joanna's pointing out here is that, okay, diabetes, there's a physician. So if you, like Carol said, if you need the oxygen, you're going to be using it, right? Patients aren't going to walk around and not use their oxygen if they really need it. But there are lots of patients that have diabetes and the doctor wants them to be on some form of treatment and the patient is non-compliant with the treatment because they either can't afford it or they don't think they need it or whatever. And so for diabetes, we really want to capture what medication the provider felt like they needed to control their diabetes. So that's the difference in these 2 fields. If that makes sense, Joanna.
makes sense to me. Okay, here's a question on the sleep studies. So what if they had a repeat sleep study and that sleep study said that there was no OSA or no obstructive sleep apnea?
I think if you've got a new sleep study and says you don't have it, then you probably don't have it. You've got new information saying no, this person doesn't have it anymore. And I suspect something must have happened to the patient or to fix or correct the sleep apnea in that situation, I would suspect. The details, though.
Thank you. If they've ever had pneumonia in their life, is it coded as remote?
Yes.
Okay. Patient has positive for COVID in-house post-op. Someone documents COVID pneumonia, but no difference in chest x-ray. Mild symptoms. Test was just done to be able to transfer to rehab center. I would definitely talk to whoever.
Well, yeah, I mean,
COVID pneumonia.
you have a provider that's diagnosed the pneumonia, okay? Now, if what you're saying that his diagnosis doesn't jive with what really is going on, then you probably need to clarify whether this patient did in fact have pneumonia or did they just have COVID without the pneumonia aspect to the COVID.
Okay. Thank you. Are these questions part included in the FAQs? I think these questions are part of the training manual Melinda's.
Yeah. Yeah, they're in the training manual, and they're not really some of them are in an FAQ format in the training manual. Some of them are in the intent. Some of them are in the clarification. It just depends. I've just pulled little aspects out of the field, the sequence number, and that I think need to be highlighted because can easily be overlooked.
What happens when it's after surgery and it says possible pneumonia? Is this an event?
No, if it's possible, they didn't have pneumonia. You're not code possible. It's like having a possible heart attack. You have one or you don't.
The COVID question that was sent prior with the COVID positive test and they document COVID pneumonia, does it count as a post-op event since it just seems like a documentation issue?
Well, I think again, if it's that question that's you're wondering if the patient really had pneumonia, I think you need to clarify with the provider because technically you do have a diagnosis of pneumonia, so you could code it as a post-op event. But if you really don't think that the patient had pneumonia or there's conflicts in the documentation, then we could seek clarification and clarify that in the documentation.
Okay. Thank you. Dope smoke is unfiltered and can cause even worse emphysema than tobacco in some people. Thanks, Beth.
I understand that. And
Yeah,
probably that would be captured in chronic lung disease fields because I know quite a few people that have pretty bad COPD because they smoke pot all the time.
Nice. Linda, can you please, this is from Linda, can you please remind me what the last temporary field was for? I'm not sure what that question is. Linda.
The last temporary field, she's probably, are you talking about the, if it's not COVID, it has to be that other temporary field about using the Impella open and be 5.0, I think.
I think we have another, we're using two other temporary fields.
Yeah, we have one for a mitral valve and we
Yeah.
have implant, we have one for the Impella, and then we have a couple, 2 or 3 COVID ones.
I would say to look in the training manual because all the temporary fields being used are in the training manual. I can't remember off the top of my head.
Yeah, I don't know which the last one was. I think it was the Impella, but I'm not entirely sure.
Great comment, Beth. Most CPAP does not use oxygen. It's just air pressure. So it's a continuous pressure and it's usually room air that it's using.
Oh.
Would it be used in place of O2? Just air, just air.
Yeah.
The question regarding the family reports patient has sleep apnea.
Oh, okay. Yeah, I answered that. I thought that's what it was, Mary. Beth answered my question.
Thank you. You're welcome. What if the family knows they have a machine at home, which would mean they had formal testing?
Well, you would think if the family has given that information to the doctor, the patient's got a CPAP machine at home, that the provider's going to say this patient has a history of sleep apnea. I would think that would be documented in the record somewhere. Because you're right, you have to have a diagnosis of sleep apnea to get a CPAP machine.
Okay, hold on 1 second. That's for Patricia and anybody else who signed on late. We're expecting the Harvest One reports to be coming out this weekend and notification will be sent on the 18th once they're posted. What if, and I'll get your question in 1 second, Christine. For Kim, it says, what if your surgeon or anesthesiologist documents obstructive sleep apnea, but there's no indication that a formal study has been done and no documentation that the patient has CPAP or prescribed but doesn't use CPAP BiPAP.
I think if you've got a formal diagnosis from a provider's not, generally speaking, is not going to say somebody has sleep apnea unless there's been some formal testing to prove that they have sleep apnea. That's okay. You've got a diagnosis from a provider that the patient has sleep apnea.
Okay. Christine, if the this is off topic, she said, sorry, but it's next to tobacco use, so she's asking anyway. If the patient has history of COPD and all the pre-op tests such as PFT, bedside spirometry, ABG are within normal limits, and patient is not using inhaler or any meds, how do we code this?
No, because the chronic lung disease is based on the criteria in the training manual. So it's based on your PFTs, your ABGs, whether you use inhaler or not. So you have all the criteria performed in this patient, it sounds like, and they're all normal, and it's not on an inhaler. And so you know what the severity of his chronic lung disease is. So you would say, no, he doesn't have it because the diagnostic tools that we use to determine it are all normal.
Thank you. Pat,
And we will, I already have my slide presentation for that. It'll be coming up probably in May or June. We'll be doing a chronic lung disease one.
okay. Pat just wants to confirm that there's 3 meetings a month for April, May, and June. There will be 3 meetings a month, and then we'll go back to 2 meetings a month. April, May, and June, we'll have 2 meetings. We'll have our monthly webinar, which is today, and then the 19th and 20th, which is today. And then on the 19th and 27th, we're going to have our quality improvement series. We have our monthly webinar in May on May 3rd, and then we'll have our quality improvement series on the 17th and 25th of May. I didn't put June dates on here, but I'll have them on for next time. The provider takes history from the patient most of the time, and that's from Marina. And then Christine says, for sleep apnea, our center uses the case manager's assessment if patient is using CPAP or BiPAP with or without oxygen. Since these are DMEs, a formal diagnosis is needed.
That's true. You can't get those machines unless you have a formal diagnosis. Marina, I think that if you have questions, if your provider believes after taking the history of the patient that the patient has sleep apnea, based on his assessment or her assessment of this patient, then I think that you got to take that as face value. I don't know what kind of testing or how they interview the patient or anything like that.
Okay. So I'm going to clarify Gabriella's question, because I think we're getting things a little muddy. It doesn't matter what they vape. Vaping is considered smoking. Doesn't matter what they're vaping. Vaping's considered smoking.
Yeah,
Smoking marijuana, we're not capturing that as smoking right now.
Right. So, like Carol said, we want to capture any vaping. Doesn't matter what they're vaping. They could be vaping marijuana, CBD, nicotine, herbs. We don't care. We want to capture that they're vaping, and the only place to capture that is in sequence 400.
Okay. Okay, any AQO updates? Our AQO decision was made that we are going to be virtual this year. It'll be the last week in September, and I'll have more information on that coming up. So virtual for 2023, we hope to go in person in 2024. Thanks, Melinda. Okay. And then Melanie saying, so you can document sleep apnea if there's a provider note regarding it, even if you can't find a formal sleep study.
Yeah, because part of the definition is, does the patient have a diagnosis of sleep apnea? And then we start talking about how we want to make sure that they really have been diagnosed with one. So if you've got a physician or provider saying this patient has a diagnosis of OSA, then you can capture that.
And then Laura's asking about the question regarding the documentation of history of COPD. She's saying, wouldn't that question be about documented history of COPD be answered lung disease documented severity unknown?
No, it wouldn't be that, because you know what the severity is based on your PFT, based on your ABG, and based on the patient not using an inhaler. You know what the severity of that lung disease is in that particular situation.
Thank you. And then there's a couple hands up. I'm gonna unmute folks and allow you to talk. If you want to chat, go ahead, one at a time. I have Darlene and Betsy and Laura. Let me see if I can get everybody here. Hold on. Anybody? All right. Anybody? Darlene and Betsy, Laura. Oh, here's Sherry. Hold on, Sherry. Okay, Sherry, are you there? Anybody? Okay. With that being said, go
Can you hear
ahead.
me?
Yep.
Okay, the April 19th ACSD quality improvement kickoff. If we're not able to attend that, will that be recorded and we can listen to it?
It will be recorded and it'll be posted with the other webinars.
Thank you.
Yeah, thank you. Give me a few days. Usually it takes our marketing team a couple days to render the video and get it ready for posting. So, and
We have one more question.
okay, and then that's it.
That's it. Why don't you pull up sequence 450 in the training room? 405. Gosh, how can I? 405 is chronic lung disease, right?
405. Yes, ma'am.
My dyslexia, 454. Okay, so the question is, if there's lung disease due to a low DLCO but no other documentation, what type of lung disease is this? So you can see down here in the green, Carol, that
Yes,
we
ma'am.
updated. We can use the DLCO, and it talks about the different types depending on what your DLCO is. So mild or moderate or severe, it's all right there in the training manual, pretty clearly laid out. If you have questions about that, Giselle, you can just send it in the FAQ mailbox.
Okay, and then just one last clarifying question from Rhonda, and then we'll wrap it up. Thanks everybody for staying on late. And thank you, Melinda. Most of our patients do not have PFTs done. Some have ABGs. Even with MD documentation of COPD, is it still coded as no, even if we don't have any other testing done?
Well, it depends on if you've got testing. If you have a PFT, then you know the severity. If you have an ABG, pretty much know the severity. If the doctor says the patient has COPD, but there's been no testing at all, and you don't, it's not on inhaler, then you can say unknown. That's a point in time you can say unknown. Well, yeah, they say he has it, but I can't determine the severity of it. That's basically what that's saying. And for those of you who may or may not know this, no, chronic lung disease present severity not documented and unknown, I'll code out as no. So when you're looking at lung disease, it's all considered no if you answer those three answers. So
Okay, I think we're good.
okay,
We're good, Melinda. We're good.
we're
everybody?
good. We're good.
All right. Well, thanks everybody for joining. Next time we'll next time we'll talk is April 19th. And again, that's the Quality Improvement Series kickoff at 2 p.m. Central Time. Don't forget, Harvest One reports are due to come out this weekend, assuming there's not a major system glitch. Look for those notifications on Tuesday. And I hope you all have a great rest of the week and enjoy the nice weather across the nation. And if it's rainy by you, I hope the sun comes out soon. All right. Thanks, Melinda. Thanks, everybody.
All right. Thanks,
Bye.
everybody.